Hello and welcome to tonight's Rural Doctors broadcast. I'm Gerry Gannon. Thanks for your company. Our programme tonight looks at palliative care. We'll speak with Dr. Anil, Tandon, Helen Walker and Valerie Colgan from the Palliative Care Network about some useful tools for ensuring quality of care, including the Liverpool Care Pathway, which provides for planning, tracking and review of care in the last few days of life. We'll also hear about the role of the Palliative Care Network and how they can support you in delivering rural and remote palliative care services. But for now, let's meet our panel. Firstly, the indefatigable Olga Ward is here once again. Hi, Olga.
Hi, Gerry.
It's a new term to describe you. And to answer her question and yours, we're pleased to welcome Senior Paediatric and Adolescent Oncologist and Palliative Care Specialist at Princess Margaret Hospital, Dr. Marianne Phillips. Hi, Marianne.
Hi, Gerry.
And Palliative Medicine Specialist, Dr. Jacklyn. Welcome along, Chris.
Hello there.
Chris, first question to you, straightforward question. What's the fundamental premise of palliative care?
It's to allow someone to die with dignity. So our goal is mainly to make sure that we don't treat them just as someone who's got no real value to their family or to the community, but as someone who deserves to be given the best quality of life for the very last and most important stage of their life.
What does that involve in terms of the treatment that you give them? Does it mean that active treatment has ceased and it's now simply a matter of keeping them comfortable?
That's a very good question. We try to emphasise with all our patients that when they're coming into our service, palliative care is an active service. It's an ongoing, dynamic, changing process. We like to respond to all of their variety of symptoms in as active a way as we can. So we have many tools that we can tell them we can bring to the table, so to speak, to make sure that this process is going to be as good for them as possible.
Well, palliative care is all about symptom management in as active a process as possible. A lot of the educational materials that GPs get focus purely on pain management. And you know, my patients seem to have loads of other issues. Could you perhaps describe some of the other problems that your patients have and how you deal with them?
Well, pain's the sexy subject. That seems to get all the kudos. But realistically, the commonest symptom that we get is fatigue. That would certainly rank right up there as being the one complaint that most or more patients would complain of than anything else, and yet that's probably the hardest to deal with.
Yeah. Marianne, you deal with children and teens. Are they also in that very fatigued group, or do they complain of something different?
They do complain of pain and fatigue. The parents often are concerned about oral intake and anorexia. One of the few things parents can do for their children is to feed them, and so a dying child creates a whole series of problems for a parent when the anorexia is taking over. If that's associated with nausea and vomiting problems, then that can be a huge combination that need proper symptom management.
Yeah. So does the fatigue arise just simply from lack of oral intake and, of course, the metabolic requirements of the tumour, or is there something else going on there that you could address?
It's quite complex, really. Fatigue's due to a variety of things. There's that cachexia type syndrome resulting purely from the tumour, but you can also be fatigued because you're producing different chemicals. Your calcium levels might be going up. You're fatigued because of the nutritional changes. You're fatigued because you're spending more time lying around because you just don't have the energy to do things, so you lose a lot of your normal muscle tone and mass. So there's a lot of factors. You're fatigued because you're depressed. You're unhappy. You're not in a good place.
Yeah. Or if the underlying problem is of leukemia, then you're fatigued because of chronic anemia.
What about the emotional issues, particularly, Marianne, around children and teenagers and the emotions of the patient themselves, but also their immediate family?
And that goes back to the original question about what is palliative care, because palliative care really should be the global management of, for us, the child and the child's family, immediate family, and often extended family. The death of a child is a very significant event in a grandparent's life. So there's the care, it goes much broader than just for the child and parents very often, the impact on siblings.
So what do you say to GPs, particularly in rural areas, who are faced with that particular situation and where very often the GP may be a friend of the family or knows the family at least very well? How do you manage the family aspects of palliative care?
I think ensuring that there's support out of the, usually Princess Margaret Hospital would be the place that would be providing the original transition across to palliation for a medical diagnosis, and so ensuring that there is ongoing support from within oncology, the oncological department, and we now have a paediatric palliative care program based out of Princess Margaret Hospital that provides input for children who are dying of non-cancer illnesses. And it's very important within our current conversation to remember that in paediatrics there is very few deaths a year from cancer, and more often the reason for referral to palliative care services is for non-cancer diagnoses. So it's important that there's ongoing support to the family from PMH and from the programs. It's important that the GP is given sensible and full information regarding what the child knows about their diagnosis, what the parents have been told, and how best to manage the symptoms within the home environment, which is usually where families would choose to care for their child until death.
And Olga, let me ask you, as a GP, have you ever been in the situation where a child has been in palliative care? In other words, a child has died on you over a period of time? And what are the ramifications for the GP?
Unfortunately, it's an awfully difficult situation for a country doctor, because even if you don't know the patient well, and in my case this was a teenager who'd come home to his hometown to die, but of course all of the family were my patients or my friends, and my staff were related to him, and everybody in the town was in and out. And then because he wasn't dying of cancer, we had the added complications of people being frightened to go in and see somebody that they'd known since before he was born.
Yes.
Just simply because they didn't know how to react, and they didn't want to see him like that. And they wanted to remember him playing football as a 12-year-old with the nippers or something. But
what sort of support was there for you, and did you feel that you needed some sort of support as the treating doctor?
I don't think there was it was a difficult situation. I felt that I had enough support from specialist colleagues, and I actually used the specialist colleagues in Kalgoorlie as much as I did the ones in Perth for symptom management. And we were fortunate that we had an experienced palliative care nurse on staff, so that's I think always very helpful for even just the simple technical things like how to load a syringe driver or symptom management. And Silver Chain Hospice were just fantastic. I could ring up one of the doctors, and whoever was on would give me some useful information. I'd say, how can I manage this patient's nausea? Or he'd been experimenting with recreational drug use, so he was soaking up an incredible amount of morphine. I wasn't all that concerned about that because his pain was getting to the stage of being well controlled, but of course the staff were freaking at the amount that was going in, so it was useful to have an external opinion sometimes just to back you up and say, well, look, this is appropriate, it is fine, he is dying, if he needs it, he gets it.
And Chris, that would be your advice to GPs: reach out for the experts who can.
Essentially, I mean, it is a team effort usually involved in managing palliative patients and their families, and part of that team is using the palliative care services that are available, and we're generally more than happy to answer calls, and we have services providing good information 24 hours a day. The biggest problem is, as GPs, by and large, we're notoriously independent and stoic and don't tend to utilise the services when we're feeling the pain or the hurt, and we just tend to plough on regardless. And that's probably the biggest problem, is just not utilising the services that are out there to help.
Is that just male GPs, Chris?
I wish, but no. The new age sensitive male GPs are not like that.
One of the things that I'm always interested in is the palliative care of patients who don't have cancer, and the kinds of resource people who are around for those patients. When country GPs are needing some help with symptom management for that type of patient, they would still ring a palliative care physician, and the same if they happen to be a child dying of renal failure or something, they would ring the palliative care unit and not the renal unit at Princess Margaret.
I think it would be important to ensure that the GP knew who to ring for a patient. So it would be fair to say that often families who have had their care of their child under a certain physician for a protracted period of time are loath to lose contact with that physician, and so a lot of the care still is going through that physician or that department. Referral to a palliative care service does not need to override any association that families and patients have got with their primary caring team. It doesn't need to replace that. It can work preferably in conjunction.
Yeah.
So it's a difficult problem though, because in adult palliative care you struggle sometimes to draw the line. We deal with a lot of, say, motor neuron disease and some of the end-stage neurological conditions, but you could almost extend that to say, well, surely Alzheimer's is an end-stage brain disease. Well, if we took on all the Alzheimer's patients, we would soon be overwhelmed and run out of resources. So it does become difficult. Certainly we're treating more end-stage cardiac failure and renal failures in adult medicine now, in the palliative care field. But as I said, we do have to draw the line somewhere, I think.
And
it highlights the need for good communication between all departments and all agencies that are involved in a palliative patient. Because as long as all the communication is in place and plans are clear, there should be no question but from the rural GP as to whom to refer to for questions for the family or the patient.
Well, let's see if we can get them at least a little bit of useful hard information as well. You were talking about fatigue and causes of fatigue, and obviously that means that we'll be doing a little bit of extra testing depending on our clinical suspicion. If you've got a patient, Chris, you were talking about hypercalcemia. If you've got a patient with hypercalcemia, how do you treat that?
Okay, well, hypercalcemia is common. About 10% of all malignancies will at some stage present with hypercalcemia. So it's quite often missed, and there are patients that will come across who are presenting with uncontrolled nausea, poorly controlled pain, just fatigue. They can present with a whole spectrum of symptoms. Mostly we would probably investigate a patient who's admitted to our service for calcium as a first-off screening test because it's such a common problem. If they turned out to have high calcium levels and they had a reasonable quality of life left, I mean, if they only had a potential prognosis of 1 or 2 days, we'd probably just keep them comfortable. If we thought they had a little longer to go, though, we'd probably give them a one-off dose of zoledronic acid, because that's quick. It's about 4 grams given over 15 minutes IV, so it's a nice, quick, easy, one-hit treatment protocol, and it may make them feel symptomatically better within 24 to 48 hours. So it works reasonably quickly as well, and can last sometimes for a month or more.
Yep. Is that something that's readily available in country areas?
No, that's the downside. And in country areas you may be really limited on what you can give, and that may just mean giving them plenty of fluids. Rehydrating them will dilute out the calcium, and that certainly will make some difference. Keeping them mobile if you can helps as well. Looking for medications that may be compounding that can be useful as well, so stopping thiazide diuretics or calcium supplements, as some of them are on. Yep. They may have APD, which is another bisphosphonate that's more readily available in regional areas. That works equally well. It's just a little slower to give and takes a little longer to kick in, but it's also an equally effective treatment.
I seem to remember having a lot of trouble getting it, but I think it was a Section 100 drug at the time.
Yes, and it is, and it's still available though in regional centres though. So I know.
I think you can get it in a small hospital. It's just the ordering process is quite tedious.
Yeah, but I said in that interim period, you could just, as I said, rehydrate them at the very least. That'll make a difference.
Marianne, do you have any other hot tips?
Well, we don't really see hypercalcemia in children. It's not a problem that is often identified.
So if you've got kids with very generalised fatigue and perhaps quite a lot of nausea, what would be the first thing you would think of as an underlying cause?
A lot of nausea is likely to be often due to the polypharmacy that many palliative care patients are on. That would be the usual cause for nausea, unless, for instance, in a brain tumour, then clearly nausea and vomiting would be driven by potentially raised intracranial pressure.
Yeah. So in terms of, looking at a cacophony of pharmaceuticals, which ones do you knock off first? What are your prime suspects, and what do you substitute for them?
Well, if one felt that the nausea was due to polypharmacy, it would be ideal to try to reduce that. Usually the polypharmacy is from a multitude of analgesic agents, and with the advent now of fentanyl patches and slow-release morphine and non-opioid opioids, the slow-release medications really are removing the need for the multitude of agents for a lot of children, certainly. It needs to be remembered that children metabolize opioids much quicker than adults, and so the doses that they're on are often seemingly extraordinarily high, but they metabolize it, and lots of studies have shown that they metabolize it almost 10 times quicker than adult patients do. So their dose per kilo body weight is often much higher than an adult physician would expect to see. Personally, I don't think there's an upper limit of an opioid that's required as long as pain is properly controlled. So one can try and remove that sort of polypharmacy. It may be that, in fact, the best way of controlling nausea and vomiting is to add something else in, and our first drug of choice is usually then going to fall to the 5-HT antagonists on dansitron or tropizatron in older children seem to do better.
Speaking of pain, which seems to be the one thing that distresses most patients, this endless undiminishing pain, and no matter, there's always the complaint, particularly from families, that they're not getting enough morphine or whatever is going to dull the pain. And a lot of people fear that when they know that they're at the end stage of their life. What do you say to people in those kind of situations?
We don't mislead them. I think in the past, medicine's been a little guilty of saying, look, we can cure your pain, but we no longer would go down that path. We say, look, we can try and make you as comfortable as we can, but it may be a bit of a trade-off. So we'll make your pain as tolerable as we can without completely bombing you out. I mean, we could make everyone pain-free. We could just sedate them and they'd have
why
no
not
pain.
do that?
Because they want to have an interaction, most patients, with their family. They don't want to be completely bombed out for the last potential months of their life. So we say it is going to be a little bit of a balancing act. We can try and get your pain to an area or a level that you feel you can cope with, but it still allows you to be alert and active, able to maybe get up and walk around or interact with your family. So a lot of it is saying, yes, we've got a lot of tools at our disposal to help you with your pain, and we will try our best to make you as pain-free as we can, but you may have to put up with some pain in order to have a better quality of life. And for some people at the very end stage, maybe when they're bedbound, it may be necessary to give them enough analgesia to almost keep them in a sedated phase, but that's not very common.
So really there is no pain-free state at any stage?
There can be, yes. Some patients we can get completely pain-free with the medication we've got and still have them alert, but it's not something we'd say we can definitely do for everyone.
Yeah, there have been quite a few other things that I've recently come across, even simple things like pressure care and making sure they're on a sheepskin or an egg crate mattress or whatever, which is still readily available in country areas without needing the electronic Ripple mattresses or anything. But there are other things that are quite distressing for the family. For instance, that horrible gurgle that patients often get when they've got a chest full of
death
muck.
rattle.
Yeah, although they sometimes have that for weeks. And they hate it, particularly when they're asleep, and of course the families are frightened. Have you got any good anti-gurglers?
No. Well, the bottom line is once you're already gurgling and you've got the secretions there, all the products we've got like Hyacinth don't dry up what's there. They may reduce the production of more secretions. But the problem is they've also got other side effects. Generally, the end stage death rattle, the gurgling we're getting in the very final stages, is when we're too weak to clear our secretions ourselves, or our gag reflex may have diminished. And it's usually more distressing not for the patient but for the family, because they're sitting around the bed hearing this glog, glog, glog. But the patient themselves, when they can discuss it with you, say it doesn't really bother them that much. If it does, a lot of it revolves around simple things like postural drainage, to make sure the secretions are draining correctly. If their prognosis is reasonable and they can afford it, then glycopyrrolum is a reasonable agent because it doesn't cross the blood-brain barrier so much, so it doesn't sedate them as much. Otherwise we use Hyacinth still, and that may reduce the production of secretions.
Now, I'm not familiar with glycopyrrolum. Is that something in common usage?
It's reasonably, well, it's certainly available, but probably not in rural settings because it's quite an expensive drug.
Marianne, is there anything different that you use?
We tend to use Hyacinth. But again, the group of problems that we see in children is slightly different. It's skewed slightly differently than the problems that are seen in the adult sector.
Repositioning them perhaps on their side, is that alleviated?
Well, as I said, postural drainage, that means positioning so the fluids drain more easily is better.
We might take a break there, Olga. What do you think? And we'll come back to this discussion later. Well, there is arguably no greater factor in the quality of palliative care in the last few days of life than good planning, tracking and review of whatever measures are taken. The Liverpool Care Pathway was developed by the Marie Curie Palliative Care Institute for precisely this purpose. It's now used widely in the UK and has been shown to improve the outcomes whenever it's in use. The Palliative Care Network has been evaluating the Liverpool Care Pathway and are about to release a version for use in the Western Australian context. We spoke with Dr. Anil Tandon, Helen Walker and Valerie Colgan about the Liverpool Care Pathway and its value in the management of end-of-life care.
One of the first initiatives that the network undertook was the introduction of a care pathway to direct care in the last days of life. A group of 31 clinicians from 12 palliative care services came together to look at best practice models in the delivery of care in the last days of life, and really decided to utilise a pathway that had been developed in Liverpool in England at the Marie Curie Institute for Palliative Care in Liverpool. And it was done so really to move the sort of care that's available to patients in hospices to other centres and facilities where patients are cared for whilst dying. The group met for several months and actually modified the pathway in collaboration with the Marie Curie Institute staff, and was then trialled at 4 health facilities as a pilot to see whether it would work to support care for patients locally.
One of the things that we do know is that rural and remote general practitioners see more palliative care patients and more dying patients than city GPs do. So in the city, patients basically go to hospitals and GPs, unfortunately, don't get that much involvement with them. And so there was a study done in New South Wales which showed that the average rural GP looks after around about 8 to 12 palliative care patients, and therefore that's how many deaths that they also see per year. And then if you compare that to the city, the average GP there looks after maybe only 5 or so patients a year. So it's a big difference. And so GPs are going to therefore have an opportunity to use this Liverpool Care Pathway, this document, to help as much as possible guide them through the care of these patients a lot more often. And what they'll find is then the more they use it, the more they'll be able to get the rest of the team on board so that the care is as good as possible, because this really is a best practice document. It's helping. We know through the research that the Liverpool group did that this, when you use it, the care is better.
So the pathway supports health teams in arriving at a diagnosis of dying in patients that they're caring for, and if you like, brings all parties onto the same page in making decisions around care and implementing the care that's ratified by the whole team, if you like. The primary care provider, in this case a general practitioner or medical officer that's known to the patient, nursing staff, allied health staff members, and pastoral counsellors and chaplains. The tool describes the patient's current physical condition and starts to look at the comfort measures that are in place for the patient. Importantly, it starts to look at the assessment of medications that are in use and discontinues non-essential medications. It reviews the process of prophylactic medication prescription for symptoms common in the dying phase, and discontinues inappropriate or futile interventions that may reduce the patient's comfort, including investigations such as blood tests and scans, the use of venous access devices, antibiotics, and anything that's likely to interfere with a patient's comfort at that time. It's divided into sections that really look at holistic needs, including psychological insight, religious and spiritual support, communication with the family and with the primary healthcare team. So really it's a tool that does bring the whole health team together, both the current treating team and then previous teams that the patient may have been associated with. The tool actually guides health professionals through the process of ongoing assessment. So it actually describes what their symptoms are like, whether they've achieved good comfort with interventions or whether they need further interventions in order to actually improve their symptoms.
The network's going to start rolling out the Liverpool Care Pathway in rural WA. We have 3 areas, rural regions, the Midwest, the Southwest and the Great Southern, who have actually volunteered to start with the implementation process, which hopefully will be by about August. We would be wanting to train champions in each region who then will take responsibility within the local community of training others around them. So that would involve the nursing staff, the allied health staff and the local GPs. So we will be commencing with the process of training people in each region, a series of I think 3 training days, and concurrently we will be doing a retrospective audit of the patient files from the last, I think, 6 months that we're going to be looking at to see what the care has been prior to the implementation of this pathway.
So I've had the opportunity of using this document a couple of times. Once was in Wales in a hospital environment and once was in Edinburgh in a hospice. And so this pathway is sort of accepted practice in the UK now. It's shown its value. When we were using it in the hospital environment, so this wasn't in a place where palliative care was core business, it was just a normal, semi-rural hospital, and so we were using it on wards where, the team weren't necessarily familiar with palliative care, they weren't palliative care experts or trained in that area, and so we were just trying to then, as much as possible, normalise the management so that everyone could do it, whether you were a young doctor or an overseas nurse who's just arrived, everyone was on the same page. The other thing then that when we used it in Edinburgh, it was in a hospice, so this was a specialist unit, and so you would think that everyone is expert and proficient in it, but in actual fact, even with the document, it showed that there were discussion points that arose along the way and that, there were sometimes different viewpoints really on how to manage someone who's dying, but this tries to uniform that, or as much as possible make their management uniform. It doesn't say that you have to, so you can not follow the pathway at various points if you really do feel that it's not appropriate, but at least it's causing you to question what you're doing.
So it's a very simple tool that staff can use to easily audit their performance in providing care, either one aspect of care or the whole spectrum of care whilst the patient is dying, and then they can look at how they can improve care for that aspect for their team.
Dr. Anil Tandon, Helen Walker and Valerie Colgan there discussing the Liverpool Care Pathway, and we'll hear more from the Palliative Care Network later in the programme. Chris, bleeding from bowel or lung cancer tumours can be very distressing both for the patient and the family. Any ideas about ameliorating that?
Yes, there's lots that can be done. It's a common presenting problem, especially hemoptysis, bleeding from the lungs. Primarily, obviously, you look for the cause because that could be a treatable condition. It could be an infection, could be just some local inflammation. Could, however, be something like a pulmonary embolus in which case you need to work out at which stage of their disease they're at, because that will determine how aggressive you want to be with your treatment. By and large, if you're just going to be treating the symptoms though, and that's often all we can do, there are still things that you can do in the rural community that are quite cheap and readily available. And the first would be tranexamic acid. Now this is, as I said, a cheap, very common medication that's been around for a long time, and it can be quite effective in dramatically slowing down the volume of blood loss from a variety of sources, but especially from hemoptysis. It's about 1 gram TDS 3 times a day, and for most patients that will slow down or stop the bleeding within 24 to 48 hours.
Do you worry about replacing that blood?
No, generally for hemoptysis, that's the coughing up of blood, the volumes are quite small, not enough to warrant replacing. And for most of these patients that we're talking about and dealing with, they can tolerate quite significant blood loss before they're going to get any symptoms. So we wouldn't even consider transfusions, say, until the haemoglobin's below 80 and sometimes less.
I've sometimes had patients who've had hemoptysis, but I think the tumour's possibly eroded into a small artery, and so they really have coughed a significant amount.
If it's significant, then that's different, and then you probably need to actually be... It depends on what resources you got.
Don't you?
Yeah, you need someone to go down there and have a look and either cauterise it or ablate the problem. If it's persistent, the best treatment by far, by a country mile, to use a rural term, is to get them to have some radiation therapy. Because radiotherapy, just a single fraction, will stop most hemoptysis within 24 hours. It's very dramatic in its benefit. So that would be the ideal solution. But if you can't, or if you have to do some holding process, tranexamic acid would be something to consider. The only caution for bleeding, and we use tranexamic acid for bowel bleeds as well, is if you're bleeding in the urine, sometimes using tranexamic acid will cause you to get bigger clots, which can cause more pain. So it's not such a useful intervention then. Not that we don't use it, you just have to be aware of that.
Marianne, same modality for teens and children?
Yes, it would be. It tends to be really the teenagers who are then going to be those who present with lung or bowel cancers. Those are unusual sites to see in the paediatric population, but it would be similar management.
Kiddies bleed from small bowel lymphomas and things, I suppose?
And unusually, they're unusual to get small bowel lymphomas. The children who bleed tend to be those who have got leukemia that has relapsed and is progressing, and we're fairly loath to presume to do regular blood counts and act on that. We tend to only presume to give blood if the child has become symptomatic from anemia, and we only give platelets in the face of bleeding. And so for leukemia patients, actually one of the best things to do in the face of bleeding is to give platelets.
Yep. And can you use tranexamic acid in small kids?
You can, yes.
Yep.
You certainly can.
They're
yes.
enormous tablets. Do you squish them up in jam or something?
Yeah, well, yes, you can crush them, or in fact the PMH pharmacy can provide a different formulation.
Well, they can be crushed, because we use them on bleeding wounds as well.
Yes, you can rub them onto wounds. Yeah.
Well, you use them topically as well?
You can be, yes. They're very versatile. If it's a rectal bleed, that's different. Now we'll put in stents, and this is just so Gerry can squish and squirm on that seat. But a significant rectal bleed, the best treatment now is for the gastroenterologist just to put in a stent, and that'll often dilate up and block off the bleeders.
You want to go there to the bowel next with your next question, didn't you?
Well, I did, but since Chris has just sort of mentioned surface treatment of tumours, I'm just wondering about the types of tumours like, say, mesotheliomas or sometimes melanomas, or even, tumours in the sinus and on the face. And they'll fungate through the skin. They often, they look terrible and they smell terrible. Is there something you can do to make it a little more acceptable for the patient and the people around them?
There are. It is a difficult problem, and I'm certainly not going to say we've got an answer for all of those fungating wounds to make them smell perfect. But we can reduce the smell to some degree if it's due to an overgrowth of bacteria that are causing it. So we will often use things like metronidazole gel, which can be soaked into dressings and applied. We can use, as we said, tranexamic acid if it's a bleeding problem that's also adding to the smell. A lot of it is to do with the dressings, so you'd use absorbent dressings, Caltrostat type dressings, just to absorb some of the exudate. So they're some of the tools we have at our disposal. Similarly, you can just put them on oral antibiotics to try and get some reduction in the overall load of bacteria, because it's generally the bacteria that are causing the odour.
What about the effectiveness of antibiotics at end-of-life stage? Are they any more or less effective, or does it matter?
for what?
Antibiotics, treating people who are in their
They're
final...
yet to kill cancer with an antibiotic.
No, but, you know, for treating these other issues.
I mean, that's a very important and quite controversial issue as well, because when people are in the final stage of their life, it's trying to draw that line of when is it going to be improving their quality of life and their dignity to treat them with an antibiotic, and when is it actually kinder to the patient to say, well, they're going to be happier just allowing nature to take its course and to die from their pneumonia in the last few days. Because quite often pneumonia is not a painful process. It actually just allows them to succumb into a coma and they'll die in their sleep, so to speak. So a lot of those decisions have to be made on what their prognosis is, what their quality of life is like at the time of the infection, as to whether you give an antibiotic. I mean, antibiotics will work, they'll treat an infection. It's not as though they're going to be ineffective. It's just, are you doing them a favour if they've got only hours left or a day or two left to live to fill them full of an antibiotic?
It usually just makes their liver shut down then, doesn't it?
Yeah, and a lot of that also comes to dealing with patients if they've given some sort of forward notification about what their goals are for when they're dying and what the family think.
Olga seems to be avoiding the issue, but I'm going to ask the question. Bowel obstructions.
Actually, part of the question was, you know, that there are many preparations for, if you've got somebody with a complete or almost complete bowel obstruction, to try and take the pressure off, apart from a nasogastric tube, things like degas and simethicone and Mintec.
Yeah.
Are they any good?
Not really. Simethicone is just a defoaming agent, so it'll stop you belching as much, and degas will stop you farting as much, but they're actually doing nothing for your bowel obstruction. They're not going to reduce the basic problem, which is building up of gases from the flora in your gut. So,
good old-fashioned activated charcoal?
We don't use simethicone for bowel obstruction or degas because, as I said, it's not treating the fundamental problem that we're dealing with. I mean, if they're, as I said, farting a lot and you want to make the fart smell sweeter, sure, use a charcoal agent. I mean, that'll absorb some of that.
What about octreotide?
Octreotide is different. There are lots of agents we can use in bowel obstruction, but they're not the sort of agents you were mentioning. Octreotide is great because it reduces the amount of secretions being put into the gut, so that at least has some good value for reducing the overall volume that's trying to pass through an obstructed gut. And again, it depends where the obstruction is, high or low. Some patients, if they're towards the end of their life and they've got a low bowel obstruction, they're quite comfortable just sipping small amounts of fluid which they'll absorb in their small intestine before it gets to the obstruction, and they don't need any other necessary intervention. And they'll cope maybe with 1 or 2 vomits a day, and they're happy to do that.
What about the people who've got an obstruction from like external lymph nodes, so that's not actually a bowel cancer? Can you use octreotide in them if they're sort of relatively active and healthy? Is it something
if they had an obstruction from a pressure effect, often we'd give them a high dose of dexamethasone, a steroid, to try and at least restrict or reduce some of that swelling around the bowel, and that may give them a period of good relief. So octreotide wouldn't be the first port of call for that.
Of course, steroids then bring a whole other series of problems, because you put someone on steroids to relieve a bowel obstruction, and you increase their appetite, and so then they want to eat more.
Well, what about physically going up there to relieve whatever is the obstruction?
Okay, you've been putting a surgeon into the picture. You're a brave man.
Fair enough.
No, in fact, I'll tell you. Look, sometimes surgery does have a role to play. So if you have a significant upper obstruction and someone's vomiting continually, and there's not much you can do to relieve that, we tend not to like to put nasogastrics down. They're uncomfortable. They interfere with the patient's ability to interact with their family. But what you can sometimes do is put in a stent, a percutaneous stent. Now that's a tube that goes through the abdominal wall directly into the stomach, and it can empty into a bag, and they can actually be fed through that, and they can also drain through that. So that is a role that's sometimes reserved for the surgeons. If they've got a reasonable prognosis and they'd survive an operation, then sure, they could have surgery to bypass a single obstruction if it's just a solitary lesion. But often these people have multiple levels of obstruction, and for that, surgery doesn't have any role.
It's certainly a peg tube for somebody who's relatively healthy and, you know, has a few months. It's a fairly low invasiveness procedure. It's something that can be done in regional centres.
But ventric gastrostomies still have some risks. And it's certainly something the patient and the family would have to have a long discussion about before they go down that pathway.
At least it's something that they don't have to all come to Perth for.
Can we talk about alternative therapies and remedies for what ails you in the palliative stage? Firstly, for pain relief, what about things like massage, acupuncture? Do they work?
Okay. The problem with these things is they probably do work quite well, but there aren't any really good trials to prove that. Acupuncture may work quite well with those sort of myofascial type pains, not necessarily for deeper pains, visceral type pains, pains from organs. But certainly they don't do much harm, and there is a theory behind why they should work. So we certainly don't discourage patients from having acupuncture. There just isn't a lot of data to support it because the trials that would have to be set up would have to involve a placebo wing, which is quite hard to do in acupuncture.
Yeah, that's right.
This is a placebo needle assistant.
What about massage?
Massage can be really useful, maybe not purely because of its physical benefit in terms of relieving whatever the underlying problem is, more because it's a caring, hands-on process, and it makes people feel that they're being cared for and looked after. So massage therapy can be a very useful modality.
Does it work in children, Marianne?
Same would apply. I don't know that it can be proven and said that any of those things work because trials haven't been done, but certainly it's a very therapeutic thing for a family for a mother, for instance, to be giving massage to a dying child is a very therapeutic thing both for the child and for the mother because it's increasing physical contact between them, and palliative care does have a significant psychological component. It's not all physical manifestations, and so things that will help the psyche are very important and shouldn't be dismissed even by us conventional medics.
Yeah, there's a lot of stuff that our patients take that isn't the things that we prescribe them, and you know, there's a very powerful placebo effect attached to many herbal and homeopathic medications. Are there any that we should be aware of that might potentially do the patient harm or aggravate a hypercalcemic state, or you know, well known to cause nausea, or is there anything we should be kind of really aware of?
Well, there are quite a few of the alternative medicines or fringe medicines that aren't necessarily safe, and that have a lot of negative consequences for the patients for a variety of reasons, not least the cost and the fact that it can offer sometimes false hope without any evidence to show that it has benefits. But things like shark cartilage went through a process of being very popular, but that can be associated with hypercalcemia and a few other renal complications. So,
what about massive doses of vitamins?
Vitamin C can also cause kidney stones. It's not good for the liver to have huge doses of vitamins. It's that classic case of people thinking if a little bit's good for me, a lot must be better. But that's not necessarily the case, and we would always encourage people when they come to us and their families to talk about everything that they're taking, including over-the-counter medications, so we can determine if it might be going to intervene with our traditional medications, and so that we can just have a frank discussion about what they're hoping to achieve.
A few of my sort of not quite in stage but definitely metastatic cancer patients are taking some stuff called jungle juice. What is it? They have no idea.
It's a juice that comes from the jungle.
That's about all we know.
Right.
Have you come across it?
No.
Okay, it's obviously something that's out there. It's thick and green and looks like aloe vera juice.
There are an enormous number of different products out there, often with some spurious benefit because it comes from a plant, which is what people like to say, well, therefore it has to be natural.
That's right.
But so does, cocaine,
arsenic's natural,
arsenic, cyanide, they're all
Vinca's
natural.
natural.
Isn't jungle
Taxol.
juice just the term given to various concoctions that people comprise? Oh, I'll chuck in a bit of that weed and a bit of that tree and the bark of that tree, I'll scrape it into it. There you get your jungle juice.
Well, there was a Mexican water
So
that was
far
being
they're still
imported a
alive.
few years ago for hundreds of dollars
Yes.
that, again, was just a nonsense.
Speaking of Mexico, Chris, a number of people have been in the media recently for having gone to Mexico to buy Nembutol, is it, or this euthanasia drug. Is this something that you come across from your patients who ask to be, put out of their misery? How do you cope with this?
Surprisingly few patients ask us to assist them to kill themselves, and yet it's a very popular topic to hear about in the press and the media. Yet, as said, in the coalface with the patients that we see, it's rarely, if ever, mentioned. Now, if it is, that's a topic we'll take quite seriously, and we'll sit down usually at a a meeting with the patient and their families and discuss what they're looking for, why they're wanting to find a way out, what their reasons are and whether we can help them through that. As a service, we don't offer assisted suicide. That's just not something that's part of our...
Well, it's not legal for a start.
That's the fundamental reason, because we can't. We can't say we'll help you because then we're at the moment committing an offence.
Well, that's right. But in those such situations, would you bring in some sort of psychological assistance to help here?
It's all a team event when we're dealing with our patients. So we always have a spiritual counsellor involved, we have a social worker involved, we'll have lay counsellors, we have the nursing and medical staff. So it's a big effort for each patient where we'll have team meetings discussing their individual problems, and whoever's most appropriate can go in and talk to them, or we talk as a group. So often they're people who are just depressed, or they're people who are afraid because they're worried about pain or nausea, and often they just need to be relieved about how we're going to manage those problems as they arise.
And there are those people too who don't want the indignity of having pipes and bags hanging off them and what have you. With children, Marianne, I don't suppose that children would ever look for it, but what about their parents? Do you ever come across a case where a parent will say, my child is suffering too much, please end it?
No, I think that with good symptom management, one sees that very, very infrequently. Most parents really are clinging to every minute of every hour that they can have with their child. Yes, and often families who have been through a protracted course with a child who's been dying do eventually profess to a level of relief when the child does die, but during the actual palliative and terminal phase they continue really to cling, hoping for a miracle, as you say, yes.
Yeah. Yes. And there's often a lot of fear of pain, and I know there are some new modalities. We're mostly quite aware of fentanyl patches. What else is out there that's you've found really good for pain management?
We've been using the non-opioids more and more, the oxycodone slow release and the oxynorm for breakthrough. It's been very useful in the paediatric population.
And same in the adult, because it's got a nice biphasic pattern, so it has a quick onset and then it has a longer acting component, so they get their relief a little bit quicker than they will with standard morphine, but it will still last for a recognisable 4 to 6 hours.
Yep, and you're finding that better than something like MS Contin?
Yes, because of, as I said, that biphasic
because of that
pattern.
Fast onset.
The fentanyl patches are fantastic, though. They've been really made a major difference to
And their
pain
only
management.
drawback, though, is that they're not good for uncontrolled pain, because you can't have the flexibility. They take about 3 days to really reach their plateau.
Right,
but the fentanyl lozenges, which are now available on the PBS for palliative care, are worthwhile remembering. And they're probably underutilised. They're quite expensive, but they're a quick-acting means of treating patients when they're going to have incident pain, or if they're going to have pain when they're moving.
Dressing changes.
Yep, dressing changes, or going to the toilet even. They have to know that they just roll them around in their mouth, they don't suck on them, but they can give them quick onset, within a few minutes, pain relief for 15 to 20 minutes, or half an hour, an hour.
So it's a transmucosal
delivery.
Right.
And then they can be back in bed or back and resting. So it's a very useful modality, especially because it's fentanyl, so it's not affected by renal function, it doesn't cross the blood-brain barrier as much, so they don't get as confused. So it's a very useful adjunct.
Very useful in anyone over the age of 3.
Good. Nice to know. Now, many of you may be involved in some way with the various health networks and their work to develop tools and strategies for improving the quality of healthcare in WA. Well, recently the Palliative Care Network secured funding to help implement some of these strategies. We spoke to Dr. Anil Tandon and Helen Walker about this funding and how it will be used, as well as other ways the Palliative Care Network can be of assistance to rural and remote GPs.
Palliative care is part of the WA Cancer and Palliative Care Network, and we have been very fortunate from a palliative care perspective to have had election promise funding from the last election, which gave us approximately 3 to 4 years of funding up to now, and that allowed us to work around some really good best practice initiatives. All the health networks have gone down the track of developing models of care. And we, for Palliative Care, developed our overarching model, and then later last year we were able to endorse our rural palliative care model. Where lots of the health networks have developed models, we're now in the very special position of being able to fund the implementation of our rural model. We actually had 100% uptake when we did a survey across every region, and really the findings of that were that while people were passionate about palliative care in rural areas, it varied very much from town to town, with some towns really dependent on individual people. And so from a health perspective, that doesn't sustain palliative care. So what the rural model will effectively do is give a structured plan for each region so that you have coordinated care across the region. So there's several layers to this. Each region will have what we call regional governance, so that different organisations that are involved with palliative care throughout that region can be part of that regional governance committee, including GPs. There will be a regional coordinator, a nursing position appointed for each region, and we're hopeful that we will actually have various other health professionals funded for each region as well. Now, some regions actually have quite good palliative care services now that have been well established for years, but other regions are very limited with what's available. And so we're looking at extra nursing positions, social work, Aboriginal health workers, and even involvement from a local GP perspective in that palliative care team. But the other components of the model that will help to support palliative care are to have special interest groups that go across each region, so that whether it be the GPs, allied health and nursing, they can actually start to link together around palliative care issues. For instance, in the southwest, we've actually got a team that started up in the last few months already, and they meet monthly and discuss palliative care issues. And already it's starting to link all the towns together.
We've planned for the palliative care network for the money to be spent on 6 main areas. So rural is the main recipient, paediatric palliative care is a second one. Thirdly is to try and fill some of the gaps in metropolitan palliative care, specifically in hospitals that don't have palliative care units at the moment and the residential aged care facilities. Fourthly, it's to try and, as much as possible, build the workforce and so provide a bit of education and training. Fifthly, it's to target specifically the Indigenous population. So that, I think, a lot of that also is really going to benefit the rural population, because clearly that's where more Aboriginal patients live. And then finally, the pathways and protocols. So in other words, things like the Liverpool Care Pathway or actual documents to guide general practitioners or other clinicians, even nurses, as to how to manage common palliative care problems. Uncontrolled pain, who has respiratory distress or breathing difficulties, what drugs to use and when, what other non-pharmacological approaches can be used. And it'll actually encourage the clinician, the doctor, to do what we call preemptive prescribing, because a lot of what palliative care really does, at least in terms of the drug aspect or the pharmacology of palliative care, is that we prepare for things that are going to occur. So in other words, so make sure that on the drug chart there are analgesics, antiemetics, sedatives or antipsychotics for the delirious patient, anticholinergics for retained secretions, those sorts of things, because we can predict that that problem is going to happen. And so rather than have the GP being rung in the middle of the night or trying to ring a locum doctor, whoever that may be, who might not know the patient, then if you do it, then you can at least control what's happening and ensure that your patients don't suffer unnecessarily.
One of the other core elements of our funding is around Indigenous palliative care, and particularly in rural and remote areas. So we would see that each regional team would actually have a plan of how they link with Aboriginal controlled organisations and how they actually provide specialised care for Indigenous people.
One of the good things about the network and also our plan to spend this money is that I really don't think, as clinical lead for the palliative care network, that this money is going to be either wasted or it's just going to go on committees or producing reports or documents. If we're talking about $14 million that is allocated for this, half of it is going on specifically just this rural palliative care component. And in actual fact, certainly components of the remaining half are actually going to also indirectly be used for rural patients when they come to the city for care. It's really devised or designed to, as much as possible, be sent out into the areas of need for palliative care to try and improve patients' management. And so I think what we're going to see is some concrete and real change for patients and their families. Since 2001, we've had a 24-hour telephone advice line available. And so the number for that is 1300 558655. And what that does is that after just a couple of easy prompts, it puts any caller through to the mobile phone of a palliative care specialist. So there are about 7 or 8 of us who participate in that roster. And a lot of the times what we find is that the calls really are people just ringing up to check that what they're doing is actually correct. And in response, what we find is that most of the time what they're doing is correct, and just giving that reassurance is important. That number links in with the visiting palliative care specialists that have been now going to all of the country regions for the last 2 years. So these doctors, these visiting specialists are going to these country areas usually on a monthly or 6-weekly basis, and going to the major towns in that area, working with the doctors and the nurses just to, as much as possible, empower the local team to provide palliative care, provide some education, just provide that consultation and liaison to build up the skills in the local area. And that really applies to palliative care in general. The whole aim is that we want to do ourselves out of a job so that everyone else is doing this as best as possible. Because a lot of the skills that we're doing, they're generic health skills, I think.
And a big thank you once again to Helen Walker and Dr. Anil Tandon for their time. Well, that's just about it for this broadcast. Any final comments or take-home messages from Chris and Marianne?
Yeah, fundamentally it's to remember you're not alone. When it comes to palliative care, we have a very good resource system in Western Australia. We have a 24-hour telephone number which will get you directly to one of the palliative care consultants. And they're all delightful people, happy to talk at the drop of a hat. Ring them anytime. Preferably 3 in the morning. They love it.
And we'll put a link to that. We'll put that number on our website.
And they're also very good text resources that are available to all GPs. There's the therapeutic guidelines, and that's an excellent resource.
All right, we'll put those links on our website as well. Marianne, any last words?
On that note, we now have the paediatric palliative care programme for the state that is run out of Princess Margaret Hospital. So that employs some CNCs within the oncology department, and also then within the non-oncology network within the hospital, and a palliative care physician, me. So you can ring me anytime, and preferably not at 3 in the morning.
and preferably not when you're doing your television programme and your phone's not with you.
Yeah. And again, there are written resources and websites, and there is specifically a paediatric palliative care booklet which provides information on drugs and drug doses, etc., and that can be sent out and provided to anyone who wants it.
Beautiful. Any last take-home message from you, Dr. Ward?
I think get on the telephone. I think that's what I did, and it certainly worked.
It always worked for you, Olga. Don't forget that if you'd like to review this programme or any previous programme, you can watch them online or download them as video or audio podcasts via the Rural Health West website at www.ruralhealthwest.com.au. We're back again on the 4th of August with a programme on Aboriginal health, including issues in Indigenous oral health. Thanks to our panel, Dr. Olga Ward, Dr. Marianne Phillips and Dr. Chris Jacklyn. And thanks to you for taking the time to join us. I'm Gerry Gannon. Good night and thanks for being with us.